This video is going to be on azotemia, which is an increase in BUN and or creatinine in the blood. Azotemia is further divided into pre-renal, renal, and post-renal azotemia, and that depends on a combination of the urine-specific gravity and clinical signs and physical exam findings. So with pre-renal azotemia, it's defined as an azotemia with a urine-specific gravity that's adequately concentrated for the species. So that's a urine-specific gravity that's greater than 1035 for the cat, 1030 for the dog, and 1025 for large animals. Renal azotemia is when there's inadequately concentrated urine for the species. So less than 1035 for the cat, less than 1030 for the dog, and less than 1025 for large animals. Post-renal azotemia is not defined by the urine-specific gravity. The urine-specific gravity can be variable, so we need to look at the clinical signs of the patient, our physical exam findings, and there may or may not be a hyperkalemia. And I'll talk more about post-renal azotemia in a later lecture. So going back to pre-renal azotemia for a moment, we can have an increase in BUN and creatinine, and if we see this, that means that there is a decreased renal perfusion, so there's decreased blood flow to the glomerulus, so that means that not enough blood is being filtered and it's building up in the blood. So there's a decreased GFR because of decreased blood flow. And the most common cause of this type of azotemia is dehydration, but certain drugs, especially the anesthetic drugs, can cause altered blood flow and decreased renal perfusion. Other causes of this type of azotemia would be a decreased blood volume, and you can get this with an acute hemorrhage or if the animal's in shock. So now I'm going to talk a little bit about an increased BUN without an increase in creatinine. So now thinking back to urea physiology, urea production is increased if there's more protein or ammonia being absorbed by the GI tract. So you can have those instances occur if there's GI hemorrhage or if the animal is on a very high protein diet. Also thinking back to urea physiology, if there's a decreased tubular flow through the nephron, then there's more time for urea resorption by the tubule. So urea is resorbed unlike creatinine. So if that tubular blood flow is decreased, then you can have an increased BUN without creatinine. So in that instances, it would be mild or early decreased renal perfusion. So now talking about increased creatinine without BUN, so thinking back to creatinine physiology, it is a better marker for GFR in large animals. And again, that's because the urea is recycled in the rumen or the cecum. So if it is increased by itself in large animals, then that indicates that there's potentially a decreased GFR. And then also creatinine is a muscle breakdown product. So in heavily muscled animals such as greyhounds, they might have a mildly increased creatinine relative to the reference interval. All right, so now going over to renal azotemia. There's two main causes of renal azotemia. The first of which is renal failure, and the second is a pre-renal azotemia with some sort of extrarenal factor that's causing a decreased urine-specific gravity. And I'll explain that a little bit more detail later, but first I'm going to talk about renal failure. So renal failure occurs when there's loss of functioning tubules and glomeruli. So when there's greater than 66% loss of tubules, then that leads to a decreased urine-specific gravity or inadequately concentrated urine. When there is greater than 75% loss of functioning glomeruli, then you start seeing decreased GFR and azotemia. So now going on to prerenal azotemia and extrarenal factors that can lower the urine specific gravity. An example of this would be if you had a dehydrated animal with something else that's affecting the kidney's ability to concentrate besides renal failure. So for example, if you had a diabetic patient with lots of glucose in the urine causing osmotic diuresis, and that diabetic patient was also dehydrated, that could cause a renal azotemia without it being renal failure. So other examples of factors that can lower the urine-specific gravity that is not renal failure include decreased medullary tonicity, such as animals with liver failure and decreased urea production. Also, decreased aldosterone concentration, like with patients with Addison's disease or hypoadrenocorticism, as well as animals with central diabetes insipidus and decreased ADH production and release, or if the patient had a decreased responsiveness to ADH, such as with nephrogenic diabetes insipidus. So it's important to note that renal azotemia does not mean that the patient has renal failure. You have to look at the entire clinical findings, chemistry, clinical signs, to differentiate what is causing the renal azotemia.